Hi everyone, I'm Carolyn Frederick. I'm part of the sensory integration group. I'll tell you that before I started this group, I thought sensory integration was actually a good thing. I thought that there was data to back it up and such. Like many people in my group, oh, I'm so sorry about the camera moving. Like many people in my group, I found out I am very wrong about that. Sensory integration actually doesn't have a lot of data to back it up. It is just believed to be a good thing. I don't think it's absolutely horrible, but it really doesn't make a whole bunch of a difference, especially compared to ABA. The study I decided to look at is for this group is a comparison of sensory integration and behavior therapies as treatment for pediatric feeding disorders. It's written by Addison, Pisa, Patel, Bachmeyer, and Milnes and Odo. Those are all the last names, which I know. None of you guys will remember, but I wanted to make sure it was in there so I'm not stealing anyone's information or anything. So anyways, the paper starts off explaining what sensory integration is, which we've already talked about what sensory integration is in previous videos, so I'm not going to bore you guys with that, and a lot of you guys know what that is. It also talks about what sensory problems are, like what causes it, supposedly and everything. The paper discusses that a lot of kids have sensory problems when it comes to eating, which I'm sure a lot of you guys have seen working with kids with autism. They have a lot of problems with different textures and such. And we know that they have a problem with this because they start coughing or gagging or spitting out or refusing foods, knocking it out of our hands, making a big fuss. The treatment for a sensory integration treatment involves a child's sensory diet, so that it's special, doing sensory things such as squeezing the legs, even though it all has to do with the mouth. Sensory integration says that you can do sensory on other people's places in the body, not just the mouth, like squeezing the arms, the legs, etc. Really helps, supposedly. So, for this paper, they had two individuals, young children, both with eating problems and drinking problems, that weren't getting enough nutrition. The OT suggested that they have a sensory-based intervention, and which actually this paper says is the most common intervention for OTs. They use sensory integration therapy for almost all of their kids. Both kids had problems with gagging, spitting out food, and crying when food was presented. I'm reading over my notes so I don't forget anything. The kids, I know, the kids were ages 1 and 3. I'm trying to find their names, but right this second I can't. Oh, here it is. Mark was a 1-year-old who had problems with refusing food. He had a diagnosis of, sorry if I pronounce any of this wrong, gastroesophageal reflux disease, high blood pressure, asthma, and a corcantation of the aorta. I have no idea what that is. Anyways, medical problems. He was taking like 5 medications that I'm not going to list to you guys, and medications stayed the same the whole time he was in this therapy. The next person in the study was Irma. She was a 3-year-old girl who had problems with taking in food and drinks as well. She had a diagnosis of developmental delays, dysphagia, and mitochondrial disorder. She was taking 2 medicines as well. I'm sorry if I pronounce things wrong. I know I am, but I don't know how to pronounce them right, so I'm sorry. They both ate some foods, some drinks, but not enough to sustain their nutritional, caloric, and hydration needs. So, the therapists. Let's go on to those. The therapists, there was eating therapists that were either interns, people with bachelor's or master's degrees. They were not OTs, they were not ABAs, they were just feeding therapists. The OT was a trained professional. She was the one who made the sensory integration therapy write-up and everything for this study. She had been a professional OT for the last 20 years, had extensive training and experience in sensory integration therapy, in pediatric feeding disorders, and was a licensed profession. She was licensed, of course, in her profession. In addition, she had advanced certification in the administration and interpretation of the sensory integration and praxis tests. So she knew what she was talking about. She wasn't just some random person off the street. The feeding therapist conducted feeding sessions in a room 4x4. They had a high chair, food, gloves, scale, drink, fluid-resistant bibs, so that, and with a crumb catcher, so that they wouldn't get all wet and such. The trained observers were also there. They were actually sitting outside the room, and they had laptops, computers, and they were scoring the acceptance versus the inacceptance of the behaviors, whether they ate the food or not. Acceptance occurred when any amount of the liquid entered their mouth and passed through the child's lips within 5 seconds of presentation. And observers also scored inappropriate behaviors. Inappropriate behaviors included the kids turning their heads really fast so that they didn't hit, I guess it's just 45 degrees or more. Hitting the cup out of the way, hitting the spoon out of the way, or covering their mouth or whatever with their arm so that they wouldn't get fed. Anything along that lines. There's a whole list of them, and problem behaviors were taken as well. Inter-observer agreement was always at least 87%, and was the mean average across them was right around 99%. Data was taken by both people in at least 26% of all sessions. A functional analysis was taken to identify the reinforcers for the inappropriate behaviors, what was the cause and such. Now, for the procedure. The procedure, each meal lasted 30 to 45 minutes, and was conducted about every 3 hours a day, like 9 a.m., 10:30, 12 p.m., 2:30 p.m., and 4 p.m. So anywhere between 1 and 3 hours a day. And consisted of about 7 different 5-bite sessions. So they had about 35 bites total, but they were broke up into 5-bite sections. I need to hurry up, I'm running out of time. And there was a 1 to 2 minute breaks in between each section. The OT developed an entire strategy for the sensory integration. The OT would do a lot of sensory integration, like squeezing the arms and the legs and such, blowing bubbles, feeling vibrating bugs, etc. for 10 minutes before eating occurred. And then during eating, every 2 sessions, they would continue with the sensory integration therapies of squeezing arms, etc. The results. When using non-contingent reinforcement, so non-contingent reinforcement and the extinction progress, the child, let me look at the graph so I'm not quoting you anything wrong. Let me show you the graph real quick so you can see it. See that high part? This right here is the percentage of acceptance. This is when they, let's see if we can do this. Right here, right here. This is the, is extinction plus non-contingent reinforcement. During sensory integration plus extinction, sensory integration alone, or extinction alone. The inappropriate behaviors were high. The percentage of acceptance was low or medium. And I think that was one other thing they took. Oh, that's all. Inappropriate behaviors were medium to high, and percentage of acceptance was low to medium. But during the non-contingent reinforcement and the extinction progress, acceptance moved up to 100%. Inappropriate behaviors moved down to almost 0 for both kids, anywhere between 0 to 5 per minute, whereas before they were hitting 40. They then did a study on what if we did a contingent reinforcement on whether the child got attention if they were appropriate and such. Once again, the behaviors dropped to 0. For the escape versus control, if they got to escape it, it fluctuated. The most important one was the extinction versus non-contingent reinforcement. So, to sum it all up, and I know I talk a lot, and I was only supposed to make like a 7-minute video, and we're already at 12 minutes. So, I'm sorry all of you guys have to listen to me. But to sum it all up, ABA is a much more successful thing, even for something like food eating, compared to sensory integration. Sensory integration doesn't have a lot to back it up. When I was looking up articles to back it up, there wasn't a lot of data to back it up. And one of the first, what is it called? The first ethical guidelines, I think there are. One of the first ethical guidelines is that our integrations have to be, our therapies have to be data related. They have to have data to back up what we do. And sensory integration just doesn't have it. It may help some kids, but until I see the proof, to me it's a phony. Whereas ABA has the backup. I hope you guys enjoyed listening to me talk a whole bunch. I'm sorry I talked a lot. Sorry for my messy room behind me. I hope you guys have a great day.